For anyone lucky enough to meet Dr. Thomas Harry Seldon, whether during his 34-year tenure at the Mayo Clinic, 23 years editing Anesthesia and Analgesia, or fishing in Wisconsin, 3 words come to mind: dedicated, inspiring, steadfast. After beginning his career in Ontario as a general practitioner, in 1936, Dr. Seldon moved his family to Rochester, Minnesota, to start training for a career in anesthesiology at the Mayo Clinic. As his reputation grew, Dr. Seldon became revered as an enthusiastic teacher, a trusted colleague, and a talented practitioner. There was nothing he would shy away from, and his enthusiasm for science and medicine was boundless. He saw what the anesthesiology field could be and helped take it there. Dr. Seldon actively served on many nonprofit boards that provided professionals connected with anesthesiology and blood transfusion the training and research they needed. Of the many advisory positions, Dr. Seldon had a unique connection to IARS and its journal, Current Researches in Anesthesia and Analgesia. After becoming directing editor in 1954 and board chair of IARS in 1956, Dr. Seldon revamped the journal, catapulting it to a 4-fold increase in circulation. In addition to his duties at the Mayo Clinic and demands as ANA directing editor, Dr. Seldon was able to publish an astounding 122 medical papers over the span of 40 years. Dr. Seldon knew, as scientists, we couldn't allow the politics between doctors, organizations, or countries be deterrents of knowledge. He understood to best serve our patients and our craft, we must always strive to be better. To honor Dr. Seldon and the values he championed, the IARS established the Th. Seldon Memorial Lecture as the equivalent of our keynote address. The Seldon Lecture, which now opens the IARS meeting, brings renowned experts to spark important conversations on anesthesiology and beyond, and to champion the pursuit of knowledge and discovery.
Good morning and welcome to the 2022 International Anesthesia Research Society's annual meeting. I feel so privileged today to introduce this year's Th. Seldon lecturer, Professor Ramani Moonesinghe. Dr. Thomas Harry Seldon, in whose honor this keynote address has been named, was an editor of one of our specialty's flagship journals, Anesthesia and Analgesia, for 23 years. He was an impressive clinician, inspiring educator, accomplished academic, and visionary leader. He was chair of the board of the International Anesthesia Research Society and had great ambitions for our specialty. This lecture was established to further the values championed by Dr. Th. Seldon. Through talks from leading international academics like Ramani Moonesinghe, we continue to further the values and goals of Dr. Seldon. Professor Ramani Moonesinghe graduated from University College Hospital Medical School in 1997 and was appointed as a consultant at UCHL in 2010, having undertaken postgraduate training in internal medicine, anesthesiology, and in critical care. Professor Moonesinghe is a National Health Service England's National Clinical Director for Critical and Perioperative Care, and she is the Director of the Health Services Research Centre at the Royal College of Anaesthetists. In her National Health Services England role, she was the clinical lead for the national critical care response to the COVID-19 pandemic. Professor Moonesinghe focuses on health services and improvement research in perioperative medicine and evaluation of novel technologies or pathways. She supports a large number of doctoral research students and collaborates internationally, including with partners in low and middle income countries. She also serves as the director of the Health Services Research Centre at the Royal College of Anaesthetists. Professor Moonesinghe's career has been profiled in the Lancet and the BMJ, and she was the Royal College of Anaesthetists Contemporary nomination for the Women in Medicine, a Celebration exhibition at the Royal College of Physicians. She was bestowed with the prestigious and extraordinary honor of Office of the Order of the British Empire by Queen Elizabeth II in the 2021 New Year's Honour List for her incredible services to anesthesia, perioperative, and critical care medicine. I'm so proud to call Ramani a friend and research collaborator. She is a great advocate for our specialty, and we are so fortunate to have her here today at this year's IARS meeting. The topic for this year's T.H. Seldon Lecture will be Harder, Better, Faster, Stronger, the beneficial legacy of COVID-19 for perioperative healthcare. Thank you.
Good morning, everyone. My name is Ramani Moonesinghe, and it is my great privilege and pleasure to deliver the Thomas Harry Seldon Memorial Lecture to the International Anesthesia Research Society meeting today. I'm very, very grateful for the invitation. So I'd like to start by saying that I have no disclosures of note for this presentation, and then move on to thanking the IARS, my friend and colleague Michael Avidan, who extended the invitation to me, and of course, Dr. Thomas Harry Seldon, after whom this lecture is named. So I'm going to talk this morning about perioperative medicine, where I think we've come from, where we are now, and where we're going. And inevitably, this will have a bit of a UK slant, but I hope that what I'm going to talk about will be of direct relevance to colleagues around the world as well. So let's think about where we've come from. And this is a sort of brief, very potted history of anesthesia, starting over on the left in 1846 with the first use of ether anesthesia in the United States, of course, but followed 6 months later in the United Kingdom. And I will talk a little bit about the UK experience in a sec. Then moving on, maybe 100 years later, to things like Schimmelbusch masks, which of course are now still used in some parts of the developing world. In the 1950s, ventilation, emerging from the polio epidemic, the use of negative pressure ventilation or iron lungs, which interestingly enough, although they've now fallen away in terms of usage, there are attempts to bring back negative pressure ventilation, certainly arising from the pandemic response in the United Kingdom, which will be interesting to follow and to explore over the next few months and years. And then finally, an old friend to some of us, the Manley ventilator over on the right-hand side, the basic minute volume divider, which I think was known and loved by many anaesthetists. Certainly the hospitals that I trained in the early 2000s were still using Manley ventilators in some operating theatres, so a familiar old friend. Now, I said I would talk a little bit more about the UK experience of the first anaesthetic. It was administered in a house on Gower Street, which is the site of University College Hospital today, which is where I work, on the 19th of December, 1846. And the picture on the left of your screen is a representation of that first anaesthetic in England. And you can see here in the background, the medical student, William Squire, who administered the anaesthetic. And you can see on the right-hand side of your screen the apparatus that he developed for administrating ether, which was named the Squire apparatus. Now, the surgeon in this operation was a surgeon called Robert Liston. He first heard about the use of ether in the United States and then got this medical student to come along and administer it for one of his operations. Now, you would think that this first anaesthetic operation was Liston's most famous, but in fact it was not. Liston is better known for an operation where the patient died. He slashed one of his assistants with the scalpel, and that person died of sepsis later, and someone in the audience died of fright. So his operation that he's most famous for had a 300% mortality. Now, I suppose in those days, the main purpose of anesthesia and anesthesiologists, as they were, was to keep patients alive and to try and alleviate short-term pain. And Divinum sedere dolorem is the motto of the Royal College of Anaesthetists, of which I am a fellow. It is divine to alleviate pain. And that is fundamentally where we have come from in terms of anesthesia, I think. Now, the present of anesthesia, of course, is substantially more sophisticated. We have better machines, we have better monitors, we have many, many different options for how we deliver anesthesia and anesthesia care. And along with these advances in technology and our better understanding of human physiology and pharmacology, of course, anesthesia has become substantially safer. So this was a cross-sectional study done in 2013 in the United Kingdom. And for a few days, we measured intraoperative mortality along with a host of other census type data, and found that intraoperative mortality across elective and emergency care was only 0.06%. So moving a long way from the experience of Liston with his 300% mortality. But of course, we know that mortality is not the only thing that we're trying to avoid when delivering perioperative care. We know that there is this huge volume of surgery that we're doing worldwide. So the estimate from the Lancet in 2015 was 313 million operations. And of course, it will be substantially more than that today. Despite that, of course, we know that there are many billions of people who do not have access to safe anesthesia and surgery across the world. In the United Kingdom, we do about 5 million procedures per year of our population of 65 million people, which might be considered surgery as opposed to non-surgical interventions. And of those, maybe 1.7 million we would consider to be major surgery, loosely defined as operations that require an overnight stay in hospital with a relatively substantial amount of trauma associated with them. For elective surgery in the United Kingdom, obviously it depends on the patient and on the procedure, but mortality is around 1% at 30 days. And for emergency surgery, certainly emergency laparotomy, it's around 9 or 10%. And we've seen substantial improvements in mortality from emergency general surgery over the last 10 years, particularly since we started auditing it nationally and really driving quality improvement efforts in that field. But perhaps this is only the tip of the iceberg, because we know even with elective surgery that significant morbidity afflicts maybe a quarter of patients that undergo surgery. And this has long-term impact. So impact way, way beyond the time that we stop delivering the anesthetic, way, way beyond the time that we stop looking after patients in the PACU. And of course, this problem is being amplified by the collision of these two very different worlds. On the right-hand side, massive advances in surgical techniques and what we can potentially do. When I was a medical student, if you had liver metastases, that was a death sentence, an immediate death sentence. Whereas, of course, today we just cut them out, and very successfully in many cases. And then on the left-hand side, of course, we have our patients who are getting older, who are getting frailer, and who are presenting to us with more comorbidities. And the collision of these two worlds, of course, is breeding an epidemic of perioperative morbidity that I would suggest it is our responsibility to try and address. And you can see here the impact that perioperative morbidity has on a simple thing like length of stay in hospital. So this is data from an audit or a quality improvement program that I lead in the United Kingdom, where we measure, a bit like NISQIP, we measure complications, risk adjustment measures and other outcomes in patients having major surgery. And the picture on the bottom right shows the length of stay for patients having different types of procedure and different specialties, if they do or don't have a significant complication, the significant complication defined as a Clavien-Dindo complication of grade 3 or above. So you can see, for example, with urology procedures, that would be things like cystectomies or other major abdominal procedures for urology, that the average length of stay is 5.2 days if you avoid a major complication, but almost 20 days if you have one. And on the top left, the table there indicates the proportion of patients in these different specialties who had major complications. And of course, physical complications and short-term complications, again, are only the tip of the iceberg. And the more you delve, the more you see that there can be some real problems for patients after they leave hospital that perhaps as anesthesiologists we have not been traditionally aware of, unless of course it's directly affected us through our friends and family. So these are data, again, from the same National Quality Improvement Programme. What we do is we measure baseline and at 6 and 12 months after surgery, health-related quality of life using a well-validated measure called the EQ5D, but there are a number of different ways that you can do this. And what this graph shows you is the change or the proportion of patients who have either no issue or a severe problem in a graded way at five grades within each domain between admission and 6 months after surgery. So for example, you'll see at the bottom there, anxiety and depression, that only 41% of patients before surgery have no issues at all with anxiety and depression, and 18% or more have significant problems with anxiety and depression at admission to hospital. And then at 6 months after surgery, those numbers have got a bit better, but still there's a substantial number of patients who struggle with anxiety and depression 6 months after the surgery. And you can see similar figures for pain, usual activities and mobility. So these are all things that we would be very aware of if they affected us in our personal lives, but we have very little sight of in our professional lives. And I would suggest that the relationship between postoperative complications and these sort of health-related quality of life issues is very clear, and that we have within our gift the ability to substantially improve postoperative complications. Now, this is a paper that many of you will be familiar with, and it's derived from data from the National Surgical Quality Improvement Program in the US. And it was published almost 20 years ago, but I think for me, this really was one of the most seminal papers that I've ever read, and it very substantially changed the way that I think about how I should practice and what I should be researching. And these are Cox survival curves of patients who did or did not have complications within 30 days of surgery. And so what you can see is the dark lines are the patients who didn't have a complication after surgery, and the faded lines are the patients who did. And what is most interesting about this is that the follow-up is very long. It's up to 4,000 days. And what you can see is that these survival curves continue to part company for quite some substantial time after surgery, indicating that the association between postoperative complications and long-term survival is significant, and therefore, again, emphasizing the fact that the impact of what we do in the operating theatre far outlasts the time that we generally interact with our patients. So I would suggest to you that the anesthesiologist of today does still have the same motivations and job to do as the anesthesiologist of yesterday, in terms of keeping the patients alive and alleviating short-term pain, of course. But our responsibilities, because of the way that medicine has advanced, do extend to reducing complications from surgery, limiting avoidable harm both inside and outside the operating theatre, and improving long-term outcome where we can. And I would put it to you that all of this has to start before the day of surgery. What we do in the operating theatre is just a small part of the patient's perioperative journey. And now I'm going to talk a little bit more about how in the United Kingdom, we're really starting to get into this preoperative assessment and optimization picture. So this is a policy document from the National Health Service. It was published 4 years ago before the pandemic, the NHS long-term plan, and it set out the key priorities for the National Health Service over the coming 10 years, pre-pandemic, so we didn't know what was about to happen to us. And if you look for surgery in this document, you find one mention of it, which talks about reducing waiting lists, so reducing the time that patients have to wait for surgery, and that's basically it. If you look for critical care, you find absolutely no reference to adult critical care, although there is quite a lot of reference to neonatal critical care and the improvements that are required there. And if you look for perioperative or anesthesia, there are 0 references in this document to either of these services. Now, charitably, that you could consider that's because the NHS at that time considered that anesthesia, perioperative care, and indeed surgery and critical care were not areas that required significant investment, because they were basically services that were okay, and patients did okay when they came for surgery, and the only thing that we needed to focus on was reducing the length of time that they waited. Now, of course, what's happened since then is that we've had the COVID pandemic, And the impact in the United Kingdom, as well as the horrendous impact that it's had directly on patients, on the way that hospitals had to respond in terms of expanding critical care and acute care capacity and so on, is that our waiting lists for both consultation and treatment have massively increased. So this is the number of patients now today waiting for first treatment in the NHS. Only about 20% of these 6 million are actually waiting for operations. The rest are waiting for outpatient appointments to see a consultant. But nonetheless, you can see that there's been this very, very significant rise that has arisen as a result of the fact that both the NHS rather shut down non-essential services in the heat of the pandemic, but also for obvious reasons, patients were less likely to seek medical help during the pandemic. They were less likely to go to their family physician. They were less likely to attend hospital. And as a result of that, a huge number of conditions have built up, and patients are now presenting for investigation and treatment. And not only is there a swell of patients presenting, but the patients are often presenting in worse health than they might have done if they had presented a year or two ago. So they've become deconditioned as a result of lockdowns, as a result of the change in the way society has had to learn to behave. In general, one of the things that I'm seeing in my perioperative clinic is that patients are really substantially less fit, qualitatively, of course, than they were a few years ago. So certainly in the NHS, in perioperative services, we're seeing all of this as an opportunity while it's come out of great tragedy and difficulty, because we have this now great natural experiment where we do have a lot of patients waiting for surgery, and therefore we have the opportunity to use that time more effectively and get perioperative medicine working harder and better and faster and stronger for patients in order to improve their health before they come to the surgery itself. So what are we doing about this? Well, of course, where we want to be is shorter waits for surgery, of course, but also we want to take the opportunity to try and improve patient experience. So our aspiration is that every patient should be fully informed about what lies ahead of them, that they should be kept up to date while they wait for surgery, that they should have shared in the decision-making around whether or not to have surgery or whether to go for other options, not just have a surgeon tell them that this is the right thing for them or not. They should know who to discuss their concerns with and how to contact them. And this is particularly important for patients who are more deprived, who are less activated, and I'll talk a little bit about activation in a moment, and less engaged with their healthcare, who have lower health literacy. They also, and particularly these same patients again, need to know what changes in their health, which might occur while they're waiting for surgery, need to be communicated to us and how to do it. It's very likely that patients in their 60s, 70s and 80s who are waiting for an operation might develop a new long-term condition such as heart disease or diabetes. And we need to know that that's happened and how to improve their health prior to coming to surgery. We need to understand their individualized risk of poor outcomes and understand how they can play a role in improving their chances of a good outcome. Because the things that we know for absolute certain is that the research evidence indicates that aerobic fitness, so your functional capacity, your ability to look after yourself or play sports or whatever, has a direct relationship, inverse relationship with your likelihood of developing postoperative complications. So patients who have become deconditioned and unfit are more likely to have postoperative complications, as well as, of course, all of those long-term conditions that we know pose risks to patients, like poorly managed diabetes, poorly managed cardiac and respiratory disease. Patients need to understand how they then can play a role in improving their chances of a good outcome, because so much can be achieved by patients themselves in terms of improving their health and fitness. And we need to empower them to be able to do that and support them in order to be able to do that. So where we want to be in terms of how we look after patients and their outcomes is making sure that the right patient is having the right procedure in the right place with the right team. And that's increasingly important, we're finding now, because patients who have been waiting a long time for surgery as a result of the impact of the pandemic on the NHS are sometimes turning up on the day going, well, actually, I'm not sure I need the operation anymore. And so we need to be sure we're reassuring them and us that patients coming for surgery actually need the treatment that they're listed for. We want to be doing day surgery by default. We think we can do 75 or 80% of NHS procedures as an outpatient, and we really want to push that. Enhanced recovery by default as well. And I know that the US is a bit earlier in their enhanced recovery journey than the United Kingdom, but our experience, I will talk about in a moment, is that simplifying enhanced recovery pathways may be a really good way to achieving longer term compliance. And the aim of all of this should be minimizing complications, reducing length of stay, and providing home-based care where appropriate and possible. And that's where we want to get to. Importantly, we also want to, in any innovation that we're developing, make sure that we address health inequalities. We know that patients of particular ethnicities, who are particularly deprived, and patients who are disabled, have worse outcomes than other patients. And this is a pre-existing challenge that existed all over the world, including in our health system and in yours. But certainly in the UK, COVID has really shone its spotlight on this issue. Now, of course, the majority of solutions to this are social and political. We need to improve housing and education and support for all of these patients. But healthcare also has a role to play, and we can be more innovative in how we support patients who are more deprived than in the way that we look after them after they've left the operating room. So it stands to reason that everybody listening to this talk will probably have pretty good social support at home, and will probably have enough money to support themselves if they're not able to work for a period of time. But of course, our more deprived patients don't have those advantages, and those are the things that mean that they're at higher risk of complications and death. And of course, with all of the innovation that we're trying to bring in at the moment, these present new risks. So for example, our move to try and digitalize as much as possible in perioperative care, including trying to support patients through apps and this and that, means that we run the risk of widening health inequalities for patients who are not digitally enabled, for example, and we need to pay careful attention to all of that. So how are we planning to achieve all of this? Our focus in the preoperative setting is better information, better communication, and improving the way that we assess and optimize patients. And this is a guideline that was published by, as you can see, a multi-professional group from the UK that I chaired last year, which set out our aspiration for how we should look after patients before surgery, and is now being adopted by the NHS. So last month, the NHS published its elective recovery plan, which is its plan for how we're going to deal with these big waiting lists and improving the care of patients while they wait. And in there is a clear statement that we're going to develop perioperative care teams working with patients before surgery to develop personalized preparation plans, which will detail both the clinical and the wider support needs. So that's the social care needs, for example, both leading up to the time of surgery and what is anticipated to be required after surgery. And the key points of what we're trying to achieve is, first of all, at the point that the surgeon makes a decision that the patient needs an operation, and that as the latest point, there should be a sharing of information from the family physician or the primary care team with the perioperative care team. So that's us as anesthesiologists at the point that the patient is added to the waiting list, so that the surgeon who is concentrated on the joint, the tumor, whatever it might be, then shares responsibility for preparing the patient with the perioperative team who will address the medical comorbidities like diabetes and heart disease and so on. We will be getting all patients listed for major surgery to complete questionnaires on things that are unlikely to be in the primary care record, but we know will be significant risk factors for poor outcome. So these are obvious things like smoking and alcohol, for example, but less obvious things like their general fitness. So we will be asking patients to complete a Duke activity status questionnaire, for example, so that we can calculate what their metabolic equivalents are and determine whether or not they would benefit from some exercise therapy or advice. We will be doing the same with nutrition, and we will be doing the same with psychological health as well. And having got all of this information, we will then triage patients into whether or not they need further review or whether or not they're basically good to go. And then we will provide that early review from trained perioperative physicians like myself, where required, to get the patients optimized in the best way possible. So if they're diabetic, we'll measure their HbA1c and we'll optimize it if it's high. If they're overweight, we will give them some nutritional advice. If they are unfit, we'll give them some exercise advice. And every patient should benefit from universal advice, and that's simple stuff like advice on activity and exercise and diet. But some will need targeted support, like that specialist support for their diabetes, and some will need specialized support. So these are the particularly high-risk patients who may benefit from, for example, structured exercise programs or nutritionist support. We're going to keep in touch with patients better than we've historically done while they wait, in order to make sure that their personal wishes and thinking about surgery has not changed, but also that they let us know about anything that's changed in their general health, and provide with them the opportunity to regularly reaffirm their intentions and or reconsider them. And all of this should lead to making sure that every patient has the right surgery in the right place with the right team. And this preoperative screening and optimization that I've described in a little bit more detail, comorbidities, including COVID-19, of course, and the two specific things that we would be looking at is the impact that their comorbidities have on their functional capacity, so their ability to exercise or look after themselves and be active, and also, of course, the condition-specific control like the HbA1c. We'll be actively seeking out frailty, multimorbidity, and polypharmacy and trying to improve these issues if we can. Actively seeking out fitness, nutrition, and psychological health, as I've already said, and then providing the basic support. All of us should be able to do this, provide universal advice and some basic health coaching, and then bring in the specialists for advanced support if it's required. And the key thing that we know is if we don't ask, we won't find out. And historically, we've not asked. And that is probably one of the things that's led to this great swell of complications that we see on the day or in the days after surgery, because we haven't taken the opportunity to optimize patients before the day. And we therefore rely on the skills of the surgeon and the anesthesiologist on the day. And that is simply not enough. So you might consider that perioperative care in 2022, certainly in the NHS, is seeing the perioperativist more as a public health physician, supporting the patient to help themselves, supporting the patient through the identification of risk factors for life as well as for surgery, because of course all of these things that we're looking out for are not good for patients in general, as well as not good for their surgical outcome, and then supporting them through targeted interventions. We have some resources that the Royal College of Anaesthetists has developed. This is the Fitter, Better, Sooner package. I would encourage you to go and look at it because it's really great stuff. There's a video and there's some leaflets, and these across the Atlantic, they're not specific to the NHS. And they provide some very basic health education to support lifestyle modification, comorbidity optimization, and improving preparedness. And the drivers for this are that we know that about, on average, 1 in 10 adults in the UK will undergo surgery each year. And the things which are bad for surgery, as I've already said, are bad for life. We know, for example, that this is data from the Global Burden of Disease study, that dietary risks, high blood pressure, smoking, tobacco, alcohol and drug use, diabetes, and low physical activity, these are all in the top 20 most burdensome diseases afflicting everyone worldwide. And we know that these are very significant risk factors for perioperative care as well and surgical outcomes. So these are the things that we have an opportunity to address. And the lifestyle modification through education, there's some basic stuff. So this is taken from the Fitter, Better, Sooner document, talking about exercise, talking about alcohol, talking about where to find additional resources, to, for example, to help patients stop smoking, and talking to them openly about their medical comorbidities and the impact that that might have on their post-operative outcome. And all of this, as well as about improving outcomes, is about managing patient expectation and reducing anxiety. Because we know that if patients are better prepared for what's ahead of them, then it's likely that their psychological outcome and their general health will be better for it. So we've drawn data from studies that we've done in the past to try and explain to patients what is likely to happen to them in terms of common symptoms after surgery, so drowsiness, thirst, and pain. And all of these things are attempting to, in one way, shape, or form or other, improve patient activation as well. And patient activation is a concept that was developed in the US, and we're now increasingly trying to address in our patients who have low activation levels, who are more commonly from either ethnic minority populations or more deprived populations, or both. And essentially, this is a measure of how engaged patients are in their own healthcare, and therefore how engaged they can be in improving their own healthcare. And there's a series of questions that patients are asked, and then patients are divided into 4 levels. Level 1 being those patients who basically say, you do what you feel is best, doc, and just let me know what you think is the right thing for me, through to level 4, which is probably everyone listening to this talk, who are going to be very engaged with their healthcare, very interested in finding out how they can help to support themselves. And of course, different interventions may be required to improve activation depending on the patient's baseline. And so things like surgery schools, which we're now running online, are there again to help. So we, before a patient comes in, for example, for a joint replacement, we invite them to come to a 2-hour session with the physiotherapist, the nurses, the surgeon, and so on, which explains to them exactly what's going to happen to them, what to expect, begins their physiotherapy journey, and so on and so forth. And again, this is all about preparing the patient so that they can take an active part in their recovery themselves. It also encompasses prehabilitation programs for diet, exercise, and psychological support. And of course, engaging patients to be involved in their care does not end on the day of surgery. So I've talked so far entirely about the preoperative setting, but the postoperative setting also provides an opportunity for patients to get engaged. So I mentioned earlier enhanced recovery and how the UK is substantially further along, I think, in terms of the years that we've been trying to do enhanced recovery well compared to the US. And one of the things that we're really now trying to promote is a sort of abbreviated version of enhanced recovery, which we're calling dreaming. So dreaming within 24 hours of surgery, i.e. drinking free fluids, eating a soft diet, and mobilizing with the support of one person. And our experience in the United Kingdom, we tried to introduce enhanced recovery in the early 2000s. There was a big national program to do so. There was financial incentivization for hospitals to do it. And what we found over the last 20 years is that we've eaten all the low-hanging fruit. So stuff that in enhanced recovery pathways we were trying to promote, like really good, robust preoperative assessment, intraoperative temperature management, perioperative antibiotic prophylaxis, and minimal access surgery. Those are all now standards of care. Nobody argues about it anymore. There's some stuff that remains too controversial and everybody argues about, such as, for example, goal-directed hemodynamic optimization, and avoidance for surgeons, avoidance of abdominal drains in colorectal surgery, for example. And there is some stuff that people generally agree is a good idea, but it takes a bit of effort to achieve it. And the early return to usual homeostasis is one of those. We've recently analysed some data that I hope will be published in the next few weeks, looking at the association between dreaming within 24 hours of surgery and postoperative length of stay and postoperative complications. And the team here, including Professor Monty Mythen, who many of you will know, who came up with the dreaming concept, have written this great paper analysing about 22,000 patients in total, but also focusing in on a very homogenous group of 7,000 patients having colorectal surgery, and adjusting for patient level risk factors and hospital level risk factors to understand the individual contribution that dreaming within 24 hours plays to reducing length of stay and reducing complications. Now, a popular refrain with things like dreaming or enhanced recovery is that it's all about the patient factors. So there's no point in trying to actively promote something like dreaming, because if the patient's younger and fitter, they'll dream, and if they're older and frailer, they won't dream. And there is a little bit of truth in that. There are some patient factors which influence whether or not patients are going to dream, but most of these are modifiable, such as, for example, preoperative anemia. We have the opportunity to reduce anemia before surgery by providing IV iron or oral iron if you have enough time. And we know that there's an association between preoperative anemia and a reduced likelihood of dreaming within 24 hours. But what we also found is that there are a huge number, much greater number of hospital level process factors which influence it. And all of these are potentially modifiable. So in particular, pain in the what we call the recovery room, and I think you call the PACU, severe pain in the PACU is a massive predictor of failure to dream within 24 hours of surgery. Having a nasogastric tube or an abdominal drain is also a predictor of not dreaming within 24 hours. So these are important targets for improvement, and you get into a sort of circular opportunity here where you can target the dreaming as both a process and an outcome measure, and then reflect back on the things that might be limiting the patient's ability to dream, like the pain, the tubes and the drains, and then try and improve those. And importantly, and this is a key issue in the NHS, is reducing length of stay. It may be less of an issue in the US, but length of stay is obviously associated with complications. And what we found is that while dreaming was associated with a lower proportion of patients having complications as well, that the hospitals with the highest proportion of dreamers had a 2-day shorter median length of stay than the hospitals with the lowest proportion of dreamers when we divided hospitals into 5 groups. So what that tells me is that there is an opportunity at hospital level to really influence whether or not your patients dream, and therefore whether they get out of hospital quicker. And interestingly, at hospital level, the morbidity rates, the postoperative complication rates were very similar, even though the length of stay was lower in hospitals that had high proportions of dreamers. Now you could ask, well, why should this be our issue? Why should we care about what happens in the 24 hours after surgery ends when we have normally devolved our responsibility onto others? But I would suggest to you that all roads end in dreaming as far as the perioperative care of the patient is concerned, and we are responsible for a substantial amount of that. So all of the preoperative health screening and optimization that I've talked about, the empowering of patients, the optimization of comorbidities, the surgical technique certainly, but the anesthetic technique and the analgesic strategy, I've already said to you, will influence whether or not a patient dreams, and therefore that makes it substantially our problem to solve. So I'm going to finish now with a bit of a futuristic look, just to give you something slightly different to think about. I've already mentioned that one of the things that has massively changed over the last 20 years, certainly since I've been practicing medicine, is this colossally fast technological advancement. So here, robotic surgery, but so many other advances in surgery and of course in anesthesia as well. And we know we're not very far away from seeing driverless cars on mainstream roads in some parts of the world at least. And we know that while there have been concerns about the safety of self-driving cars, this is a newspaper article or a news article from a few years ago, that the potential benefits are massive. So if you see at the bottom there, this clip that I took from Wikipedia, that road traffic accidents caused an estimated 1.35 million deaths worldwide in the year 2016. And you think about how that figure could potentially be revised if we went fully driverless, and therefore avoided human error, there are massive, massive gains to be made. And it's not a completely dissimilar story in anesthesia and anesthesiology, is it? Because these are our national audit projects that we've now got 7 of. We're doing one at the moment on perioperative cardiac arrest. And one of the consistent messages in these reports that have been led by my colleague and friend Tim Cook, who is pictured there, is that when catastrophe happens, whether that's accidental awareness during general anesthesia, whether it's death or harm, serious harm from airway management, or whether it's serious harm from central neuraxial blockade, that in part at least, and in very substantial part, it is down to human factors rather than anything else. And so, as with everything else, humans are being gradually engineered out of the system. So this is a paper that's quite old now, it's almost 10 years old, but it describes a closed loop TIVA system and compares the use of that against the standard of care with an anaesthetist or an anesthesiologist providing the total intravenous anesthesia, and found that this entirely closed loop system was better than humans at maintaining depth of anaesthesia within predefined limits. And of course, most of us that use total intravenous anaesthesia will rely on the algorithms contained within the syringe drivers. But it's not just about keeping people asleep, is it? It's about everything else. And this is a study from Maxime Cannison and colleagues, which looked at closed loop systems for providing goal-directed fluid therapy. And again, in a very small proof of concept study, found that using a closed loop fluid administration system was feasible, and importantly, that the protocol was followed more reliably than if humans were involved. Now, all of this might remind you a little bit of the situation in aeroplanes, where we have, if you go on a long-haul flight, you have the plane flying on autopilot for much of the journey, but you still have not one but two pilots in the cockpit there to make sure that everything is going to be okay. Because we know that however good autopilot systems are, they cannot foresee every eventuality, such as, for example, the bird strike, which requires the skill of a highly experienced pilot like Sully was to safely guide the plane into safety, in this case, in the Hudson River. Now, for us anesthesiologists, the metaphorical equivalent of a bird strike is, of course, our friendly surgeon. And we are the people that are there to try and support picking up the pieces if something goes wrong with the technical aspects of the surgery. But even now, even today, surgeons might be starting to be gradually replaced. So we know that when we use robots in the operating theatre at the moment, you still need a surgeon to actually operate them. They sit in the console playing with the joysticks. But this is an article that was published 2 years ago describing a cognitive robotic system for simple surgical tasks. So this isn't an entirely autonomous system. So the question that I'm putting to you is, when will machine take over from man, and how is that going to affect us as anesthesiologists? So I graduated from university in 1997, and I think in those days, man was probably better than the machine in healthcare in general. Today, I would suggest that in the operating theatre, I wouldn't really like to give an anaesthetic with ether and a Schimmelbusch mask. And so the combination of me and the machine, the anaesthetic machine or the TIVA syringe driver, is better than me on my own trying to keep the patient asleep and free of pain. But in 25 years' time, is it possible that the machine will be better than the man? Well, I would suggest that that's already the case. I would rather have an anaesthetic machine than an independent anaesthetist. But the more important question is, will the machine be better than the man and the machine? i.e., at the moment, we have the pilots in the cockpit to manage the scenario where the bird strike comes. But with the way that artificial intelligence is going and so on, how quickly are we going to move to the situation where actually man interfering in automated processes is going to make the outcome worse? And actually, the machines will take over completely. Now, if you think that that is unlikely, then I want to, in my final moment, introduce you to the concept of technological singularity. So here on the x-axis is time, and on the y-axis is intelligence, and the blue line represents human intelligence, and the red line represents machine intelligence with that very, very steep rise. So the time axis, there's Alan Turing in the 1940s developing the first computer. This is about now. A young attending, retirement time maybe 2055. Someone who's a current intern might retire in 2065. The point of technological singularity, where machines become better than humans, is predicted to be 2045. And this doesn't mean machines being better than humans at playing chess or playing Go, because we know that that is already the case. This means machines being better than humans in the full cornucopia of what it is to be human. So unloading the dishwasher or loading the dishwasher, really technical task actually when you think about it, the machines will be better. And who's to say that they won't be better than the humans in entirety at the delivering of anaesthesia care? So could it be that if we stand still, that this progression of how anaesthesia has gone on over the last 200 years might end up with us all actually having to be on a beach in Hawaii, rather than, sadly, the way that we're all sitting at home listening to these talks today, because there'll be nothing less for us to do in the operating theatre. My suggestion is that partly because it's the right thing to do for patients, and partly out of survival instinct for us as anesthesiologists, we've got to really get to grips with the concept of perioperative medicine, really get to grips with the fact that our responsibility is to the patient before and after surgery, as well as during it, and really embrace the concepts that I've described today. So I think that the future of perioperative medicine is with us as a public health physician. We should remember that surgery is a teachable moment for patients. They come for surgery, they may never have interacted much with healthcare until that time, and it's an opportunity for them to take a hold of their general health and fitness, and we can help them with that. And we've largely, certainly in high income settings, largely fixed perioperative mortality. So now what we need to do is reduce avoidable harm that impacts patients in the longer term. And preoperative optimization, highest quality intraoperative care, which we provide already, of course, enhanced recovery principles and long-term follow-up are the keys to doing all of that. So thank you so much for listening. It's been a real pleasure talking to you this morning, and I look forward to some debates and some questions. Thank you very much.
Professor Moonesinghe, that was a tour de force, and what a wonderful talk. Thank you so very much. There is already a question in the chat, and I encourage members of the audience to type your questions into the chat, and I will deliver them on your behalf. I also have some questions of my own. There's so many questions that arise from that wonderful talk. Let's start with Max Keltz, from University of Pennsylvania. He asks, first of all, compliments you for your phenomenal talk. And he was struck by data showing an apparent drop in the size of the waiting list that occurred in 2008, and suggests from your graph that demand appeared to remain below the baseline for the ensuing 67 years, and asks why you think this occurred. Was this related to the financial crash or some other factor?
Michael, thank you. And thank you, Max, for the question. So in fact, it wasn't anything to do with the financial crash. But it was a different type of money issue. There was a massive injection of money into the National Health Service in the early 2000s. So during the Blair government, we had really long waiting lists. You know, people were commonly waiting 18 months or longer for orthopedic surgery, for example. And the Tony Blair's government made a commitment to reducing that from the tagline was 18 months to 18 weeks. And so we set targets within the NHS that meant that hospitals had to achieve high compliance with patients being treated within 18 weeks of referral. And if they didn't, then they would get financial penalties. And at the same time, the government gave money to hospitals in order to incentivize, to enable them to do that by creating more capacity within the system. So a bit more simplistic, good old money talks.
Thank you. Question from Canada. Professor Beverly also compliments you on your excellent talk, and asks if you can further comment on engineering out the human factor and the value of well-defined intraoperative management protocols and standard care pathways.
Thank you, Dr. Orser. So I'll take that in two parts. So I think the first part relates to technology itself. So, and I'm afraid I really am a firm believer that technology does hold the answer to patient safety. It doesn't yet, but I think that is the future answer. I think the more that we can engineer humans out of the system, the more likely we are to protect patients. And I think that's the same in all sorts of ways. So very simple things that we've all been exposed to, like, for example, the fact that we've now moved away from being able to connect bupivacaine to IV lines, for example, or vincristine to stop vincristine being injected into the spinal cord by accident when you're giving methotrexate at the same time. These are all things that used to happen and used to cause catastrophic consequences. And as a result of simple engineering changes, we've engineered them out of the system. So I think so that has to be a focus for us. And I think in anesthesiology, we already have it. We have target controlled infusions. We can set the end tidal anesthetic agent in our anesthetic machine rather than sort of dialing up and down the desferrine, or we don't use desferrine anymore, but the sevoflurane, whatever it is. And so, yeah, I think we have it up to a point, and the next step is going to be the physiological management as well as the sedation. So closed loop intraoperative hemodynamic management and postoperative as well. And I think there's already massive advances on that coming. In terms of management protocols and standard care pathways, again, the more that we can standardize, but also take an individualized approach, the better. And I don't think those two concepts are too conflicting. I think the key is we know that for at least 80% of patients, this is the way that we're going to do things. We're going to give them these drugs. We're going to use this monitoring. We're going to, aim for these targets in terms of their physiological management. And then on the in the 20% of patients in whom that's inappropriate for whatever reason, that's fine to deviate from that. But then we need to understand that deviation. So we need to document the reason for it. And then we need to then be able to have the opportunity to study it later. And I think those are the basic principles of enhanced recovery. And I think they hold true across all of healthcare.
Thank you. We have a question here from Dr. Misha Peruansky from Wisconsin, who thanks you for your talk and asks, how do you see the role of scientists, researchers, discoverers, and physicians in these roles in the race against AI?
That's an interesting question, because thank you, Dr. Peruansky, because it's interesting because it feels a bit loaded to me in the nicest way. It feels like we are in a race against AI, and I would put it to you that in healthcare, at least, we should be joining the race in AI. I'm not sure about constant surveillance, the fact that my watch is listening to me the whole time and all those sorts of things. Clearly, in terms of personal privacy and all those sorts of things, there are some challenges. But I think in terms of the use of artificial intelligence in healthcare, my firm belief is that we need to embrace it and run with it, because in the end, one day I'm going to be a patient, and I want the best possible care that can be provided to me. And I'm going to talk in a few minutes about risk prediction. We know that using AI methods, for example, in risk prediction, we can potentially massively improve not just the quality of the risk prediction, but our understanding of the potential for error in it. And I think these sorts of things are going to seriously transform the way that we deliver healthcare and make it safer for everyone. So I think the biggest role that we have to play is to not put up too many barriers to it. I think we've all seen Everett Rogers' diffusion of innovation's normal curve, and I think we need to try and be on the side of the early adopters, if not the innovators, as far as we can.
Thank you. Great answer. So really, Misha, the answer for the scientists and the researchers is to join in and help advance the science in this regard. Question from Federico Ciardi. What should a curriculum for perioperative medicine targeted at residents and fellows include in order to meet the upcoming needs of our specialty?
Thank you, Federico. That's a great question. We've got in the UK, we've got a curriculum for perioperative medicine developed by our Royal College of Anaesthetists, and that's available for anyone to look at. But essentially, it is that holistic care of the patient from the time that they're contemplating surgery through to the long-term follow-up, and thinking about the role that we can play in all of that. So I really do believe that perioperative physicians are required to support the optimization of patients before surgery. Yes, of course, we can go to diabetologists, for example, or cardiac cardiologists, if patients need specific interventions. But the overall holistic approach to perioperative care, I think, should come from those of us that understand what happens in the trauma of surgery and in the aftermath of it. And I think anesthesiologists are the best placed for that. So robust generalist medical knowledge, obviously the knowledge that we already have as anesthesiologists and the knowledge of surgery that we have through that. But very importantly, I think also caring about those longer term outcomes and assuming some responsibility for that, which is, I think, something that all colleagues working in surgical perioperative healthcare have perhaps not embraced as fully as we could have done until now.
Thank you. We have an interesting question here where Johnny Kent asks you, Professor Moonesinghe, should anesthesiologists have better training in artificial intelligence and healthcare informatics in general? Machine learning is seldom taught, and even fewer individuals understand the deeper mathematical underpinning.
Thank you, and nice to hear from you, Johnny. So, yeah, I think the basics should be taught. I mean, I remember, but it's got to be applied. So I don't know what the American board exams are like, but I remember when I was studying for my FRCA, which is our anesthesiology professional exam in the UK, learning kind of 2x2 tables of which tests you use for parametric and non-parametric data and all this sort of thing. And it was a bit dry and not particularly useful. So I think, yes, I think we should have better training in understanding the basics of healthcare informatics, but it's got to be highly applied. So that means training people in critical appraisal of research papers, for example, helping them to understand the basic statistics and so on through peer review and so on, and focusing on that rather than just being able to trot out, you use a t-test in this situation.
Thanks, great answer. We have a question from Professor Renee L. Gabalawi from Canada, from Winnipeg. And she says, thank you so much for the fantastic talk. It was wonderful to see the dialogue around the importance of perioperative psychological health. I was fascinated by the discussion around artificial intelligence and medical technologies intraoperatively. I am wondering if you also see a role of artificial intelligence in the preoperative period with respect to triage, some of the targeted interventions discussed, for example, identification of those with low functional ability, poor psychological health, etc.
Absolutely, definitely, yes. And I think that there is so much that we can gain. Looking at the way that private industry has exploited big data, we are so far behind. So, looking at, for example, the stuff that Google or Amazon or whatever have access to, so shopping habits, geospatial data, all those sorts of things provide such amazing insights into people's lives. Applying those same principles to medicine and understanding patients' basic health, I think we can make massive advances in that. And we're already starting to make a bit of effort towards that in the UK. We're also starting to look at, for example, if we look at whole waiting lists, can we use artificial intelligence techniques to try and prioritize patients better? So rather than just going first come, first serve, can we identify the patients that are potentially at higher risk and need to be operated on sooner? So there's work emerging on all of that. And I think it's a really exciting field.
Thank you. Thank you, Ramani. Now we're moving a bit west to the United States, to the University of Colorado. And Jason Brainard compliments you on your outstanding talk and says that you mentioned the importance of perioperative exercise, weight loss, and glucose control. Are there ways in which our specialty can be more successful In achievement of these goals, then our primary care colleagues with similar aims for all their patients, any future role for technology or artificial intelligence?
Thank you, Jason. So yeah, I think there's a really good chance that we could be more successful depending on the individual circumstances and how we pitch it to the patient, because that I mentioned that sort of teachable moment that surgery could be, or perioperative care could be. Patients trundle along, not doing enough exercise. Okay, so I trundle along, not doing enough exercise, and perhaps not looking after my diet as well as I could. And plenty of people they continue to smoke cigarettes because they think that no harm will come to them until it does. And then that teachable moment when they're told that they need surgery, even if it's relatively minor surgery, provides that opportunity for behavior change. And so it's how we then tailor the way that we approach patients individually to them. That's the critical thing, because some patients will see this as an opportunity for behavior change and run with it, and some will run far away from it and try and bury their heads in the sand. And some of that will be related to their level of activation, and some of it will be related to the way that we interact with them and how we make them feel. And so I think there's a massive amount of science to be explored in how we communicate with patients in order to improve the likelihood that they will take control for themselves of their healthcare. And I think the perioperative setting provides a really unique opportunity. And yes, certainly there could be a future role for technology and AI, in the same way that we now rely on automated systems to book our flights for us rather than the travel agent on the whole. I think there's definitely roles for technology there.
Thank you, Professor Moonesinghe. We now jump from morning in Colorado to afternoon in Germany. And we have a question from Professor Christian Werner, who is currently the president of the Board of Trustees for the International Anesthesia Research Society. And Professor Werner asks, are you designing a new role for anesthesiology, leaving the operating theatre and intensive care unit as our exclusive stage into a high-profile generalist role? This may well be the future at times where cardiology, surgery, etc. are siloing in favor of patients.
Thank you. And Dr. Werner, absolutely 100% yes. I really feel that, so when I was training before I did anesthesia and critical care, the medical specialty that I felt most attracted to was geriatric medicine, because it felt like the sort of last true inpatient generalist specialty. And then I found intensive care and anesthesiology, and I feel that they are, the last true generalist specialties. And I think that we have that overall holistic view. Nobody knows whole body physiology as well as anesthesiologists do. So yeah, I absolutely agree that that is our role in the future. And it will be high profile because the number of patients presenting for surgery is just going to continue to rise and rise and rise.
Thank you. We now have a question from Valerie Villeneuve, who, again, everyone is complimenting you on a brilliant talk, and asks for you to comment about the risks related to the technologies to which you refer. That people certainly can understand the rebooting needs, but what about the terrorist hacking and I guess other collateral problems that could occur with the technologies to which you're referring?
Thank you, and what a great question, Dr. Villeneuve. So yeah, I accept fully that there are those risks, and IT is not the strong point of the NHS in which I work, and we know that we're at risk, perhaps not from cyber attacks, well, not from terrorist hacking, but from cyber attacks of all sorts, and we've fallen victim to it. Thankfully, not with a very much patient harm, but a huge amount of administrative, craziness that has arisen as a result of that. So yes, there will be risks related to the technologies, and I guess the backup systems are important. This is, me straying a bit out of my lane in terms of cybersecurity and so on. But yeah, I absolutely do accept that there is a risk associated with that, and therefore implementation has to be cognizant of that.
Thank you. And just to say, I'm loving the activity in the chat and the high level of intellectual conversation that has been generated. Tim Tran, going back to University of Colorado, Dr. Tran is appreciative of the insightful talk and asks, how do we as clinicians maintain our creativity and critical thinking advantages above standardization with artificial intelligence? Part of the reason why I enjoy being an intensivist is managing complex issues that protocols currently cannot address.
Thank you, Dr. Tran. Another brilliant question. Yeah, it's an interesting one, isn't it? And I think, so let's think about what we can, so artificial intelligence systems are based on data that we have. And from that, we draw assumptions on how people are going to behave, or how systems are going to work, and so on. No system is perfect yet, probably never will be. And one of the things that I think we don't have really good insight into is other people's deep-seated feelings. So let me explain that a bit further. If you imagine the terrible situation that you're an intensivist, needing to make or have a life or death conversation with a family, about their relative. If you think about your own family and you think, or your close friends, how confident do you feel that you could predict each and every reaction to a particular scenario? And I don't feel confident that I would accurately predict the way that my husband or my parent or my sister would behave in a particular setting. So I think that the complex issues that we will end up managing will be less about the blood pressure and the urine output, and much more about the decision making around treatment pathways and so on, working with patients and their families on which way treatment should go, which choices that they should be making, and I think that is the way that all of healthcare will eventually move, because the technical bits will increasingly be automated.
Thank you. And really, I think we should all be embracing these fresh challenges as exciting and not feel dispirited, but rather energized by the opportunities, is what I'm hearing from you, Professor Moonesinghe, with these answers. Dr. Michael Mathis now from the impressive University of Michigan, Go Blue, again compliments you on your incredible talk. Thanks you for your inspiration and vision. Considering how advances in technology could potentially exaggerate existing healthcare inequities, particularly among patients with limited access to technology, how might we mitigate this challenge?
Thanks, Michael, and thank you, Professor Mathis. And we met many, many years ago when I was a junior intensivist, so I remember you well from there, and it's really nice to see you virtually. So it's the really wicked challenge that we're trying to get to grips with in our health system, because there is this relentless push to digitize everything, and we know about this risk of widening health inequalities. Now, at the moment, we don't have very sophisticated answers to this, because we within healthcare can only do what we within healthcare can do. So all we're trying to do is put safety nets in. That means that if we create a digital questionnaire for patients to answer and they don't respond to it, then we pick up the phone and we phone them. And if that doesn't work, then we write them a letter, and all those sorts of, and go back to really traditional ways of communicating with them. But it's a bit low tech, all of that, and really I think the answer has got to be societal, and that's out of many, I mean, I don't know who's listening, but I would guess it's largely out of our control. So at the moment, I think as healthcare professionals, all that we can do is put a bit of put a band-aid on the problem. And ultimately, the solutions will have to come from government.
Thank you. So there's another question subsequently which builds on Dr. Mathis, but before getting to that, Joshua Bloomstone asks, Dr. Moonesinghe, you show Dr. Curry's data. They show the relationship of morbidity and longevity out to 4,000 days. Why then do we focus so much on 30-day mortality?
Thank you, Michael. And hi, Josh. Nice to see you too. Yeah, because it's easy. That's all. That's the reason. Because it's easy. Because it's easily measurable, and also it kind of makes intuitive sense that that short-term outcome will be the responsibility of the surgical perioperative team. And you go much beyond that, and people start to think, well, you know, it's about society, it's about this, it's about that. And I think, and that's the reason why the Curie data was so transformative for me, because it really challenged that paradigm. Yeah, so, but I think in that succinct answer, because it's easy.
So we need to be more aspirational than easy. Tika Munda asks, thank you, Dr. Moonesinghe, for such a great lecture. And then in a similar vein to Dr. Mathis's question, how do we ensure that when new technology is introduced, that it is assessed for equity in terms of the results produced? And Tika Munda is thinking of the pulse oximeter paper that came out recently in the NEJM, showing that it performed differently based on patient characteristics.
Thank you. And Dr. Munda, another great question. I think that the answer is in regulation and legislation. So we're actually doing some work on this in the UK. Our health secretary is of Asian ethnicity. He's taken it on as a personal challenge to address exactly this issue that you've raised. So we're doing some work in the Department of Health and Social Care in the NHS to look at all equipment and all protocols. We've invited healthcare professionals to contribute their thoughts qualitatively and quantitatively where they have data on where they think there could be sources of health inequality specifically related to ethnicity or racial background. And so that review is then going to spark a sort of overhaul of the technology that we currently use that's licensed for practice. And I think in the future, our regulatory authority, which is the Medicines and Healthcare Regulatory Authority, the MHRA, which is a bit like your FDA, is going to incorporate these issues in the way that it assesses new technologies and gives them permission to be used.
Thank you. We now have a question from one of the most prestigious departments of anesthesiology in the world, which is Washington University in St. Louis. And Dr. Bradley Fritz, who is conducting very impressive research in machine learning and prediction of perioperative outcomes, is very thankful for your talk, and says that one of the aspects that is difficult or even impossible to incorporate into artificial intelligence is patient values and preferences. If we move towards automated care pathways, how can we make sure that patient values remain part of the decision-making process?
Thank you, Dr. Fritz. It's a great question. And I think my response is similar to that I gave to Dr. Tran earlier, which is that that's where the humans come into their own. We have to have, that's the bit that the humans must get involved with and remain involved with, is making sure that we take patient values into consideration when making decisions. Now, I think that, you know, we can let an artificial intelligence probably run its course in the operating theatre in terms of, hemodynamic management, for example, titrating drugs, that sort of thing. But when it comes to the big decisions about pathways of care, then I think that we're still going to have to get involved. And then the interesting thing is going to be eventually whether an AI is developed that passes the Turing test, and then that will all be done.
We'll have a few more questions, and I know we could go on forever, but we will be mindful of time, and the session has about another 8 minutes to go. We have a question from Srikantha Rao, who asks if intravenous ketamine, and this is a lovely provocative question for you, if intravenous ketamine can treat treatment-resistant depression, then perhaps an anesthetic with EEG guidance and artificial intelligence and machine learning prior to surgery can be used to precondition the patient to modify their level of activation and thereby their behavior. Such an anesthetic would be offered as a treatment for the intended behavior change.
Wow. I mean, thank you, Dr. Rao. I mean, really, wow. Yeah, I mean, that sounds like a great experimental medicine grant. Seriously. I mean, I think we're doing some more basic things than that around, for example, using virtual reality so I'm leading a trial where we're using a virtual reality intervention in children, not as a distraction therapy, which is how VR is usually used in healthcare, but as a preparatory tool. So we take the kids on a tour of the hospital, and it is their actual hospital, and take them through the whole process of coming into hospital, going to the anesthetic room and all those sorts of things in a VR world in the few weeks running up to the operation. But what you're suggesting is substantially more interesting, I think, and sophisticated. And yeah, I mean, very, very interesting.
So we'll take 2 more questions from the chat. We have one here from Olu Bukola Nafia, who again thanks you and asks you to comment on the often ignored problem that many of the algorithms used for AI do not account for, which is minority populations, since we know that the one-size-fits-all care is always problematic.
Thank you, and what a great question and comment. Yeah, it's a big problem, isn't it? Now, the way that we are trying to address that, certainly in our health system, is by making sure that ethnicity in a basic way is included as a variable in all of our sort of health records and so on. But it's really imperfect, isn't it? Because, for a start, how one describes one ethnicity is a bit blunt. So I usually, when I fill in population statistics, I'm classified as Asian, British, other. I mean, is that very helpful? I'm not sure it is. And then, of course, people may not fully understand their own ethnicity. So my children are all adopted, and I know what their ethnic background is from their birth families, but they will probably grow up considering themselves to be half Asian British other and half white British other, which is what my partner is. So it's really, really difficult, and I think we need better solutions.
So the last question from the chat, and then I'll ask you a brief question and then invite you to share any closing thoughts with all of us. So we have Professor Michelle Humedin from Ohio, who felt very stimulated by your lecture and says the potential to reallocate what may evolve after initial investment costs to be very significant cost saving with increasing artificial intelligence seems so encouraging to help bring more financial support to areas of perioperative care that need it.
Yeah, I agree. And I think, notwithstanding the challenge posed by the previous question about how we account for the lack of granular data around ethnicity, for example, in AI algorithms, I think that there is this opportunity to use the technology to level up. So yeah, I agree with you. I think it is a real opportunity.
And then I'm going to let one last question slip under the wire from Professor Ben Palanca from Washington University in St. Louis, who thinks your talk was wonderful and asks you to speak on how the blending of artificial intelligence into our specialty will translate into developing countries or areas with shortage of anesthetists. Do you anticipate issues of equity and bioethics?
Thank you very much, Dr. Palanca. So yeah, I mean, of course, there could be those sorts of issues, but what's interesting is I think that in some lower income settings, they're really racing the charge on these sort of modern technologies because they see it as a way, again, of leveling up existing inequalities. So if we can train systems to do work that humans would otherwise have been trained to do, then that is likely to be more sustainable in the long run in lower income settings. So, and I think conversely, if we in high income settings like the United Kingdom and the US end up largely using AI type systems, then the way that we distribute our workforce will be different, and that will give us an opportunity to actually support across borders better than we currently do. So I think, yeah, potentially huge opportunities there.
And then Professor Moonesinghe, I have one final question for you, and feel free to share anything else that you'd like to as we round off the session. My question for you is, how do we become more patient-centered in anesthesiology? You referred to shared decision-making and touched on this. And how do we achieve better public understanding of the importance of perioperative care to public health and to patient outcomes?
Thank you, Michael. So how do we become more patient-centered? We need to ask rather than tell. And we need to encourage patients to ask rather than be told. So we're really trying to promote something simple, which is BRAN. It's an acronym. So BRAN, so B stands for benefits, R stands for risks, A stands for alternatives, and N stands for do nothing. And we're trying to encourage patients to take that structure when they go to healthcare appointments to help them understand what their options are and therefore make the right decision for them. And certainly when I see patients in my perioperative assessment clinic, one of the questions that I ask the patients that high risk is, tell me about your day. Tell me about what happens when you wake up in the morning through to when you go to bed at night. And it's incredibly instructive. And I think the other thing that the machines might be able to help us do is create the time to have these conversations. And then in that way, we become more patient-centered, ironically. And then in terms of the public health messaging around the importance of perioperative medicine, so we are in an interesting situation in the NHS where, the trouble that we're in terms of elective waiting times and so on is now really big news again, because it is worse now than it has been since that bump that the first question, the person that asked the first question observed in the early to mid 2000s. So for us, we're going to seize that opportunity to then talk to the public about how they do have choices and they do have power over their healthcare. And I would suggest that in systems or in cities or and so on, that there are opportunities there to do that in the US and everywhere else as well.
All right. Well, as I said, we could go on for hours with this conversation. You've addressed all the questions in the chat. This has been a wonderful Seldon lecture and a great and stimulating discussion to follow. Professor Moonesinghe, on behalf of all of the members of the IARS board, I thank you sincerely for joining us and for delivering this brilliant lecture. And we are delighted to have you join us for this and other sessions within the annual meeting. Thank you to all the people who joined this great session. And I hope that you continue to derive great benefit from all the other scientific offerings at this meeting. Bye, everybody, and thank you so very much.
Thank you so much for the opportunity. Thank you, Dr. Avidan. Bye, everyone.